All right, good evening, everybody. Thank you for joining us tonight. On behalf of the Pharmacy Technician Committee and Education and Professional Development Committee, I'd like to welcome you all to today's webinar entitled Knowledge is Power, Patient Safety in Health System Pharmacy Settings. We are thrilled this evening to have Jill Estrin as our guest who will present. Jill Estrin, MPH, CPhT, has a Master of Public Health Education and Promotion, and a Bachelor of Science degree in Public Health from National University in San Diego, California. She obtained her MPH while working full-time and being a single mom. Currently, she's an implementation manager for IntelliGuard, a position she's held for more than 10 years. IntelliGuard is an intelligent inventory management solution using RFID technology. Prior to that, she was a pharmacy technician for 16 years at Rady Children's Hospital in San Diego, where she held the positions of pharmacy technician and business analyst / revenue cycle pharmacy technician 2. In that latter position, she had operational oversight of a $20 million pharmacy budget. Jill was able to implement many cost-saving measures by revisiting previously established expiration dates and dispensing practices for high-cost medications, a change that continues to save critical revenue for Rady Children's Hospital to this day. She's a licensed pharmacy technician in the state of California, and she is a certified pharmacy technician. She loves to travel as much as she possibly can with her husband and spend time with her 5 children. So that is Jill's information, and she will begin presenting in just a few moments. Before we get started, I'd like to share a few quick points. For anybody who has joined us this evening as an attendee who has any kind of technological issues during the presentation, please use the chat function in Zoom to communicate with the office, and every effort will be made to assist in resolving that for you. For anybody who has questions during the presentation that you would like to direct to our speaker, please use the question box within Zoom or the chat function. And of course, the CE code for this program will be provided at the end of the program when our speaker is finished with her presentation. I will deliver the CE codes. There will be a brief, only a few minutes presentation about joining the New York State Council of Health System Pharmacists for anybody with us tonight who is not yet a member, but who might want to be. So with that, I am very pleased to wish all of us here today a very happy Pharmacy Week and to turn it over to our speaker, Jill Estrin. Jill, take it away when you are ready.
Thank you, Krista, and good afternoon. And you're on the West Coast, which I am, or evening on the East Coast. I'm coming to you from Carlsbad, California today, where I live. I do spend a lot of time on the East Coast, though, so it's near and dear to my heart. But anyway, thank you for joining me today. I did have a vision of a TED Talk type scenario where I'm on a stage, being dynamic and walking back and forth, but here we are. Anyway, I'm so honored to be able to speak with other pharmacy professionals who know firsthand how much precision, vigilance, and collaboration it takes to keep patients safe every single day. I'm currently the Director of Implementation in IntelliGuard, as Krista stated, and we provide RFID-enabled medication management solutions. And my journey there was not a straight line. I've been licensed in the state of California since the 90s. I don't mind dating myself, but and it wasn't just, I didn't just get here. I worked at a busy pediatric hospital. And over the years, I moved through about every corner of the pharmacy world, every kind of position that you can imagine a technician filling. I filled that position and then spent more than 10 years as the pharmacy business analyst. But every move I took, every step, it just made me have a deeper appreciation for how fragile medication safety can be when even one process breaks down. And I eventually just found myself drawn to this intersection of technology and pharmacy where automation and data can protect patients, but only if we understand the workflow behind everything that we do, the technology, the software, and how we interact with it. That's what led me to IntelliGuard 11 years ago, where I've spent the last decade leading more than 80 hospital implementations across the country. I've worked on workflows, trained staff. A lot of times people do ask, kind of what I do. So that's why I like to put that out there too, kind of what I'm doing now based and also where I came from. So when we talk about medication safety, I'm not talking about it from a distance. It's from the perspective of someone who's seen how fragile that safety net can be, and more importantly, how powerful it becomes when people, processes, and technology all align. And I wanted to share some insights and strategies grounded in evidence, but also shaped by real-world experience. Over our time here tonight, we can explore where medication errors come from, what industry leaders like ISMP and ASHP recommend, and how we can design safer workflows, communicate more effectively, and strengthen the culture of safety in every health system setting. And if anyone on this talk tonight is going to ASHP, I will be there. Please come by and say hello. So when we talk about medication safety, we're really talking about a system of systems, an intricate web of people, technology, environments, all designed to ensure that the right patient gets the right drug in the right dose by the right route at the right time. It sounds simple, but as everyone in this room knows, or in this call, sorry, the reality is anything but simple. Even with the best intentions, errors can happen. A medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm. That definition is broad on purpose because errors can occur at any point: prescribing, transcribing, dispensing, administering, or monitoring. And it's often what's very striking is how normal many of these contributing factors can appear. A missed decimal, a look-alike vial, a delay in the pharmacy queue, a moment of distraction. Each one by itself might seem small, but together they can form a perfect storm. Medication errors have multiple root causes, and the most common include communication breakdowns between prescribers, pharmacists, and nurses, illegible or incomplete orders, similar drug names and packaging, lack of standardized concentration, storage practices, technology gaps, systems that don't talk to each other or they're poorly configured, and of course, something near and dear to all of us, I think, is human fatigue, workload, and cognitive overload. I think that's something everyone can identify with. In other words, medication errors don't happen because someone isn't trying hard enough. They happen when systems aren't strong enough. Studies estimate that at least 1.5 million preventable adverse drug events occur in the US each year. The cost of these events exceeds $3 billion annually, not to mention the emotional cost to patients, families, and clinicians involved. A personal experience I will share with this situation of how the emotional cost to the clinicians involved actually involves a group of folks I met that work in supply chain. And there was a code, and the providers went to the director of supply chain and said, hey, that item wasn't available to us. And the patient expired. So we're trying to figure out what happened. But long story short, the entire staff, they were very devastated by this. They completely redid all their systems because they were like, how could this have happened? Was this our fault? The whole team was looking through everything, trying to figure out what went wrong, and it really, really affected them, and it drove big change within that department. But so I think that's something that we should all think about. I think that the emotional toll when mistakes happen is very real. But behind every statistic is a story of near miss. I think everyone can identify with near misses. There have been many that have stayed with me for many years, and it reminds me that in pharmacy, safety isn't just about accuracy, it's about structure and culture, and designing systems that make the safe thing the easy thing, not the hard thing, but the easy thing. The data consistently shows the errors are most likely to occur at 3 points. Prescribing, where incomplete information or decision fatigue can lead to inappropriate choices. Administration, where interruptions and distractions are frequent. and transitions of care where handoffs and documentation are critical but often inconsistent. Pharmacy plays a pivotal role in each of these. We're the bridge between data and decision, between medication and administration, between technology and human behavior. To understand medication safety, we also have to understand human factors. Human factors is the science of designing systems that align with how people actually think, behave, and make decisions under pressure. Think about the difference between a system that blames an individual for missing a step versus one that redesigns the process so that step can't be missed. That's the evolution we're all part of. And the evolution requires us to shift from a mindset of who made the mistake to how did our system allow that to happen. Today, healthcare is more complex than ever. More drugs are managed, more data, more transitions, more technology, and unfortunately with fewer people. That's a perfect setup for risk if our systems aren't continuously evaluated and improved. But the good news, challenges bring opportunity. And when we take a step back and look where the errors come from, we can see patterns, and those patterns can guide meaningful change. Organizations like ISMP and ASHP, that's where they come in. They spent years studying errors, gathering data, and providing actionable recommendations that can help us move from reactive fixes to proactive prevention. Sorry, you could probably hear me flipping my papers. I apologize for that, but I didn't want to leave anything out. So when we talk about medication safety in a meaningful way, we have to look at the guidance from organizations that have dedicated themselves to studying it. Two in particular, which we've just covered, which are the ASHP and ISMP, have provided a foundation that everyone can learn from. I encourage everyone on this call to visit their websites and look at the resources that they have available. There's a lot there. Can't recommend that enough. Their recommendations aren't just theoretical. They're drawn from decades of real-world data, root cause analyses, and lessons learned from thousands of hospitals, clinics, and pharmacies, just like the ones we all work in. ISMP has a few key philosophies that I wanted to, so we have ISMP, we have ASHP. I just want to keep these on the screen long enough for everyone to see. So the ISMP philosophy is centered on a few key ideas. One, errors are predictable and preventable. Instead of waiting for harm to occur, we should study where and how risk is most likely to appear. Two, system design determines performance. Human beings will always make mistakes, so it's our responsibility to create environments that make it harder for errors to reach patients. Three, and there's more, I'm just numbering them to keep track of myself here. Reporting saves lives. ISMP has built one of the most trusted voluntary reporting systems in healthcare because they understand that transparency drives improvement. And last, learning must be shared. Every institution that experiences a medication event has knowledge that can prevent the same event somewhere else. These ideas form the backbone of what we refer to as a culture of safety, one that replaces blame with accountability, silence with transparency, and individual heroics with system resilience. Some of ISMP's most actionable recommendations include things like standardization of drug storage and labeling, keeping high alert or lookalike drugs separated, clearly labeled, tall man lettering, something we all are aware of. That's a simple change that it dramatically reduces selection errors. Barcoding and automation validation. One thing I feel particularly strongly about is that technology should never replace human vigilance, but it can provide a safety net when it's used correctly. Independent double checks for high alert medications, insulin, chemotherapy agents. Independent verification remains an effective barrier against harm. Education and simulation, training that replicates real-world scenarios helps teams recognize risk factors before they occur in actual practice. ASHP complements ISMP's work by focusing on leadership and organizational structures that support safety. Their guidelines on preventing medication errors in hospitals emphasize that safety can't depend on a single champion or department. It requires commitment from leadership, active participation from all staff, and continuous measurement and feedback. ASHP's framework also asks three critical questions every institution should be able to answer. For example, Who is responsible for medication safety? The answer should be everyone, but leadership has to define ownership and empower action. How are errors identified, reported, and analyzed? The best organizations create processes that are psychologically safe. Where can staff report near misses without fear of punishment? And I will add too that I have seen these programs in action, but what I have seen happen is that then becomes a burden of stopping what you're doing, taking the time and writing this stuff down or reporting it, up the proper channels. I think that's important to emphasize that too. It's not just about having a program in place, it's about sticking to it and finding the time to make that important. How is improvement sustained? Safety is never finished. It's a living process that evolves as new drugs, technologies, and challenges arise. Absolutely. I have some firsthand experience with that as well when, a brand new drug was received that was never used in the hospital. Nobody knew how to handle it. Turns out there should have been special handling for this medication, but there was not. So luckily nothing bad came of it, but it was just a matter of, I have a label for this drug, let's order it. The drug comes in and nobody stopped to talk about it and say, look, let's take a time out. In my day, those didn't exist. The morning or afternoon huddles didn't exist. Those are somewhat new for me to be seeing that out there. I wish that maybe existed more when I was in the hospital working every day. Other organizations also play vital roles. The Joint Commission sets national patient safety goals that align closely with ISMP and ASHP, reinforcing their recommendations such as medication reconciliation, safe labeling. The FDA, on the other hand, focuses on upstream prevention, ensuring that drug packaging, labeling, and naming minimize confusion before the medication ever reaches the pharmacy shelf. Together, all these organizations form a network of safety intelligence, and each learning from the others to strengthen the system as a whole. So, where do we all fit into this? We are all uniquely positioned to translate these recommendations into daily practice. We're the core, and we can bridge that gap with clinical knowledge, operational workflow. We understand how drugs move, how the data flows, and how people behave under real conditions. We need to take ownership of medication safety, and then things will change. Policy can become practice, technology can be meaningful, safety becomes part of our culture, not just part of compliance. Because understanding best practice is only half of the equation, the other half is applying them in environments that are messy, as we know, human, again, we know, and unpredictable. That's probably the word I want to emphasize the most. Strategy, design, and creativity can all come into play. So, I'm just checking my time here. Wow, only 15 minutes in. Hopefully everybody is not bored by now. So we'll talk about how we actually prevent errors before they reach the patient. And if we're honest, every hospital, every pharmacy, every operating room already has policies that say the right things. But safety isn't in the policy, it's in the workflow. It's in the work that we do, it's in all of us. It's in the dozens of micro decisions that happen every day when we fill a tray or a Pyxis or an Omnicell, drop a medication, when a pharmacist verifies an order, or a provider draws up a medication at the patient's bedside. The first strategy is to move away from individual blame and toward a systems-based approach, which means not asking who made the mistake, but where did the system fail? In a systems model, we look for upstream barriers. Was the label design confusing? Did the software default to the wrong dose? So, those are just simple things we can look at, not exactly the human errors. When we treat every near miss as data and not as a failure, so looking at the things I just mentioned, we can create learning systems instead of punitive ones. Simplification and standardization. Variation is the enemy of safety. Every time a medication is stored, ordered, or prepared differently from one unit to another, we increase cognitive load on the people during the work. So hopefully I'm making that connection back to things that we've already discussed. And that's why leading institutions have moved forward with standard concentrations for infusions and high alert medications, standard order sets, pre-built templates, consistent storage layouts across satellites, crash carts, anesthesia workstations. Personally, in my even working with a vendor with IntelliGuard, I've helped numerous very large health systems standardize their crash cart trays, for example, so that if providers go from site to site, so you take a hospital with 10 different hospitals in the system, anesthesiologists can find the same drug in the same location every single time. Nurses can find the same drug in the same location every single time. I've actually helped, like I said, many systems organize that throughout their entire system. So not an easy task, talking about hundreds or up to 1,000 crash cart trays in total. So when everything looks and feels the same, it really is easier to recognize when something doesn't belong. An example I can give of that is that when I did work in the IV room, they made a certain concentrate heparin for NICU patients, and I would see that same drip day after day after day. These are for the babies. And then one day we had a new pharmacist, and I got the label, and I'm like, this doesn't look right. And I went to the pharmacist and said, hey, this looks a little different than what I'm used to seeing. No problem. She entered it incorrectly. She corrected it. Label printed out. Life went on. But I didn't just robot it. I stopped and I said, hey, this is different. And I worked in a hospital and with pharmacists that were always open to that kind of communication and appreciated it. So that's what I'll just repeat what I said. When everything looks and feels the same, it's easier to recognize when something doesn't belong. So automation is another powerful tool, but only when it's implemented with intention. Barcoding, RFID, automated dispensing cabinets, smart pumps. All of these things can strengthen the medication safety net. They can also introduce risk if workflows aren't aligned. Technology shouldn't be a substitute for human oversight. It should be an extension of it. So again, I have a lot of real world examples, and just to be able to connect with everyone out there. I used to make TPN. I would watch the machine. I would watch it pump. I would see what's happening. It was a complex machine at times. Sometimes it was simple, but other times it was complex. But I did learn where things can go wrong and where the technology stopped, and I began by watching things. I could see bubbles going through, but yet the detector wasn't saying there was a bubble. So I'm like, something's not right. So that was just me interacting with the technology, using it how it's supposed to be used, but not relying 100% on it, and still using my eyes and experience to know if something isn't quite right. Some of the most effective practices I've seen, obviously using RFID tracking to verify medication presence and expiration in trays or carts before they leave the pharmacy, integrating smart pumps with EHRs to ensure accurate dosing, regularly auditing barcode compliance, because we all know about barcodes now, how challenging those can be at times. They are changing all the time, and there's more changes to come. The lesson here, simply, technology adds safety when it's configured, maintained, and used the way it was designed, and users really need to understand why it matters. Data is also one of our greatest allies. Scans, alerts, overrides, these all tell a story. There's a lot of safety things that are put in place. I had one incident, oh gosh, I hope this is a really long time ago. I remember it correctly, but there was a drug, rifampin, both the IV and the oral form, both red. And the nurse decided that she got an oral rifampin and she was trying to inject it. Now, she couldn't connect the two because that's for safety reasons, but she was calling to find out why not. And because it was red, and that's all that she was worried about. It was red, and she was trying to give it IV, but it was in an oral syringe, and she couldn't figure out what was going wrong. So, there's human oversight. The lesson here is simple. Technology is safe when it's configured and maintained correctly. So I just wanted to let us all understand why that matters. Another cornerstone strategy is independent double checking, especially for high alert drugs. And the key word here is independent. That means the second person must perform their own verification without being influenced by the first. I have family members who have been treated for cancer. I've watched their double checks in action, and I have to say that I can't say this enough. It should be independent. It should be with not another person there, because I think that there's that kind of bias. If one person's saying yes, everything's fine, it's not so easy for the other person. I think they think, oh, well, this person already checked it. I don't have to be that careful checking it. So this is something I also feel very strongly about, is an independent double check. And when done correctly, double checks catch an extraordinary number of potential errors. And when done superficially, they can create a false sense of security. And hopefully I provided a good example of what that might look like. To keep them meaningful, double checks should really just be where the risk truly justifies the time investment. That will make sure that, the staff has time to do them well. Again, like I've seen this, firsthand, where one nurse is there, she's like, hurry up, can you come here and give me a quick double check? It shouldn't be that way. They should be allowed to take the time and effort that's required to do this important double check. Environmental design, something that, it's maybe as 30 years ago, I didn't have a word for this, but when I think now about environmental design, something we don't think about necessarily as medication safety, but I believe is critical. Lighting, noise, interruptions, clutter, even workflow layout all influence accuracy. Research shows that interruptions during medication preparation are among the top contributors to dispensing errors. Simple interventions like a quiet zone for order verification, or using visual cues to indicate a do not disturb period. I chuckle because I've often witnessed people doing that in the pharmacy, one person talking to another person that clearly doesn't want to talk. And I know I can't hear anyone, but hopefully that everybody had a little chuckle at that as well. These can all make measurable differences. And I actually experimented in when I did work at a pediatric hospital here. I noticed the technician that was filling all of the oral syringes made a lot of errors, but she was also trying to be responsible for call it manning the window. Anyone comes to the window, rings the bell, knocks on the door, phone calls, people trying to talk to her trying to talk to other people as well. And I did an experiment. So I would watch the pharmacist check all the oral syringes. So at this hospital, everything's unit dose by patient. They're drawing up 300 to 500 syringes, oral syringes every single day. And she was running around. She'd lose her spot. She forgot where she left off. So I said, hey, let's try some experiments for a few days. You're going to only focus on doing this. No one's going to talk to you. No, you do not have to answer the phone. You do not have to answer the doorbell, someone knocking on the door. And let's see what we can accomplish. Let's look at her, her error rate. So working with the pharmacists and technicians, we were very successful in showing that the uninterrupted person, I think she didn't make any errors over that time period, where normally she was making several errors a day, which the pharmacist caught, of course, but ideally, we don't want any of those errors. So the human mind, again, can only process so much, and even experienced professionals make mistakes, even if the environment is not designed to limit distractions. Our last strategy that I want to talk about is education. Ongoing simulation and scenario-based training brings policies to life. When teams experience things like a mock code, a mislabeled file, or failed handoff in a safe setting, they develop the muscle memory to respond correctly in the real world. That was part of my job as well. So I know that they would train. We did do a lot of mock code training. So that was, I thought we did well in that. And I do believe in that, because if you've never opened an emergency syringe and put it together, it can be a little nerve-wracking to try to do that in the moment. So just to wrap that part up, I'm going to say, to truly prevent medication errors, we will strengthen systems, not just individuals, simplify and standardize processes, use technology as a tool and not a crutch, treat data as a signal for improvement, maintain redundancy for high-risk tasks, design environments that support focus, and never stop educating ourselves and our teams. Each of these strategies reinforces the other, and together they can create what every hospital strives for, which is a resilient medication safety culture where errors are caught, learned from, and most importantly, prevented from reoccurring. So I just wanted to put this up on the screen while I go to the next section, because I will be mentioning these acronyms and they're on my screen. So I just wanted to put them up so that everyone had, kind of a good visual on what these actually meant. And before I get to communication, interdisciplinary collaboration, I'll just leave this here for a moment. Before I get to my last couple of sections here. And you'll notice in my first point here, I use SBAR, and we'll actually come to that definition after this slide. So this is my communication slide. And so no matter how advanced our systems or how sophisticated our technology becomes, communication is at the heart of patient safety. Every single medication that reaches a patient represents a chain of communication, from the prescriber who orders it, to the pharmacist who verifies it, to the technician who prepares it, to the nurse or provider who administers it. If one link in that chain weakens, the risk of errors rise. So we often talk about technology and policy as the pillars of safety, but communication is the bridge that connects them. It's what turns good intentions into reliable outcomes. And communication isn't just about transmitting information, it's about ensuring understanding. If you think about how you work, even working with my kids and in training staff, I have to do a lot of training on our product, on our software. I hire pharmacy technicians that I also have to train. Even with our customers, I want to say, tell me what your understanding is of this. How do you think it works? And explain it back to me, because not until someone explains something back to you do you find what gaps or misunderstandings there may be, and this is absolutely critical. Communication isn't just about the transmitting, so it's about the understanding. So I just wanted to reiterate what I just said and kind of bring that back full circle. So effective teams use structured communication tools rather than relying on memory or personality. And this is where the SBAR comes into effect. And I will explain that, and then I'll show it on the next slide. One of the simplest and most powerful communication tools in healthcare is the SBAR, which stands for situation, what's happening right now, background, what context does the listener need, assessment, what do I think the problem is, and recommendation, what do I need or suggest happens next. SBAR creates a shared mental modal between disciplines. It gives people a format to speak up clearly, confidently, and respectfully, even when hierarchies or stress might otherwise silence them. When everyone uses the same structure, conversations become faster, clearer, and safer. Another critical communication moment is during handoffs, whether between shifts, units, or departments. This is something, again, I've experienced firsthand when I have tried very hard to communicate something, but I was definitely a problem in this scenario. I knew that we were getting a non-formulary concentration of a drug in. It's one we didn't carry. The one we normally carry wasn't available. I ordered it myself. I wrote on the board, hey, this is coming in tomorrow. Please note that this is a different concentration that we normally use. So I write that on the board thinking everybody's going to see it there and everybody understands what I'm talking about. I know it's going to come in from McKesson the following morning. So I arrive to work and I'm going to go check on this situation because I knew there was a label left there. I knew we were expecting the medication. And I walked into the receiving area and I see all the totes have been opened. Somebody was looking for this drug and cut open all the totes, tried to find it. Somehow a label for one concentration got placed on a baggie with this other concentration in it. So first of all, it was filled incorrectly. It was checked by a technician, checked by a pharmacist, and it was tubed to the unit. So I see all this unfolding and I'm like, oh no, how has this happened? I thought I communicated this. I thought I gave everyone a heads up, but then, it all happened during the night shift when they're, again, fatigue, distraction, people are tired. So what do? I'm like, oh no, I run down the hallway to med-surg just in time to catch the tube as it came out of the pneumatic tube system and avoided it getting to the patient. But that was a close one. And like I said, you can see that there was a lot of errors that all occurred there. And number one was my communication. That was a fail on my side to not make sure that this was all fully understood, and try to put in something other than just writing it out on a board and hoping that everyone saw it, because certainly that did not happen. I have to find the part where I left off. Okay, so and that was just about what the next section I was going to get to is this kind of critical moment during handoffs, and that's exactly what happened. Research shows that medication errors spike during transitions of care because assumptions sneak in. We assume the next person knew what we know, saw what we saw, or noticed what we noticed. Standardized handoff tools, checklists, verification steps can close that gap. They transform what used to be a casual conversation into a structured safety process. For example, I work a lot in the OR with anesthesiologists, and I have to be present during surgical cases to help with our technology should there be, an issue or anything like that. And I've actually seen this happen in anesthesia workflows where, the provider's requesting something, and I think there was also an anesthesiologist or CRNA, and then there was also a nurse, and the anesthesiologist said something, the nurse repeated it back, and it was something other than what the anesthesiologist said, and luckily it was all audible, it was a confirmation, and that was a mismatch. It was not the right medication. So that was able to be stopped immediately because everyone was communicating, verbalizing what they were doing, using. To truly strengthen communications, we also have to address psychological safety. So the belief that it's safe to speak up, ask a question, or admit uncertainty. Can't stress that enough. I am very fortunate in that I've always worked in a environment, a teaching environment, where I was always able to ask questions, I could learn. All the pharmacists I ever worked with were so great at teaching me things and answering all my questions, and I learned a lot, and I did appreciate their time and effort they always took to explain all of those things. I always felt that the more I knew, the better I could do my job. Knowing simple things like, sometimes I would round on PICU patients, and I would go in, I would see like all the, their list of IVs that they had. It would say Nimbex, and I would say, hey, I know what Nimbex is for. And they would say, yeah, we're going to extubate the patient later. I'm like, okay, well, we don't need that. And I'm like, so could you please write a DC for that when you're sure you don't need it? A lot of times those kinds of things are missed and not followed up on. I had worked with other technicians who just made more drips of everything, not inquiring, like, is this actually needed? Because nobody wants to waste medication or do unneeded work. And honestly, having a medication in the room that is not prescribed for that patient is also unsafe. And a lot of times those kinds of things do fall through the cracks where we don't get the DC orders in time. So all of this stuff is just sitting around where could potentially be used even though it's no longer indicated. In high-performing teams, people don't fear judgment or punishment for raising a concern. They know that their voice matters regardless of their title. When this culture exists, people catch errors before they happen, and when it doesn't, near misses go unreported and small issues grow into major ones. So part of our job is to create environments, and I mean all of us, is to create environments where everyone feels respected and heard. And medication safety is inherently interdisciplinary. It requires alignment between pharmacy, nursing, and OR. Everyone brings their own expertise. Right. Flipping the pages, my pages stick together. When collaboration works well, it looks effortless, but that ease comes from deliberate design. Regular rounding, shared dashboards, daily huddles. Like I said, that didn't really exist I'll say in my time, really, I know I sound like a really old person, but in my time, that just didn't exist. And all of these small habits build trust and transparency. And leadership always plays a huge role. The tone a leader sets in meetings, emails, or huddles defines whether communication flows or stalls. As a leader in my company, I try to be approachable. I want people to come to me with honest and open feedback. When leaders listen actively and admit mistakes and thank people for raising concerns, that behavior cascades. And like I said, as a leader myself, I've seen how this can work. Every team watches how its leaders respond to feedback. If the response is open and constructive, communication can thrive. If it's defensive or dismissive, it shuts down. So one of the most powerful tools a leader can use is simply this: curiosity. Ask questions, seek to understand. We can build teams that are not just compliant, but actually committed. Good communication doesn't just prevent errors, it creates efficiency, trust, and job satisfaction. And when people feel informed, they feel valued. And when they feel valued, they take ownership. And that's the ripple effect of a safety culture. And then, as promised, I put the S bar up here for everyone if they wanted to note. This helps with a better visual. Thanks to ChatGPT. I'm not afraid to use resources when they're available to me. And then I just put just something up here for everyone to think about while I cover my my last section, which I might be even wrapping up just a little bit early. I have my stopwatch set, but anyway, I just put this up for everyone to consider before we get to the end. And I want to bring everyone back to the simple truth that drives our work, which is medication safety is not a single action, it's a continuous practice. It's not one policy, one training, one technology that keeps patients safe. It's the culture we create, the habits we reinforce, the conversations we're having, even when it's hard. So, in revisiting a couple of the ideas we've explored today, medication errors are predictable and preventable when we look beyond individuals and examine systems. Organizations like ISMP and ASHP, again, just a reminder, if anybody is coming, I'll be there with IntelliGuard. I'd love to see you and meet you in person. ASHP, they've given us powerful tools and frameworks, not just checklists, but mindsets for creating environments where safety is a default and not the exception. Standardization, technology, and data analytics can also help close those gaps. We've talked about how communication and collaboration, those help and those reinforce the idea that every one of us, from technicians to executives, plays a role in protecting patients. Even though medication safety can feel like an abstract concept, it's not. And in the way a technician checks, expiration dates, in the pharmacist who double checks a dose late at night, in the provider who pauses for confirmation before administering a drug, all those small acts multiplied across shifts and sites save lives every single day, most of which we'll never know about. Safety is also about vigilance, not paranoia, but awareness, a willingness to ask questions. Asking questions is something I feel very, very strongly about. I think my curiosity has made me a better person, and I always appreciate seeing that in my team when they're curious and they ask why. At times, yes, it's exhausting answering everybody's questions, but it's really, really necessary, and I do appreciate all of it. I'm not afraid for anyone on my team to challenge assumptions, and I will do that as well. To speak up when something doesn't seem right, even if it's inconvenient or unpopular. And again, I think sometimes there's a culture of someone's always, pushing back, asking questions, or just taking the time out to do that. And my hope is for the future that things will change so that we don't have to be on autopilot, just running from one thing to the next and hurry, hurry, hurry with, no resources, no staff, sick calls, no coverage, that everyone can have the good feeling that they've done a good job and not rush through it and not question everything they've done that day. Um, Everyone is a leader in medication safety. And leadership isn't about a title, it's about influence, consistency, and courage. And when you model the best practices, others will follow. And when you take the time to explain the why behind a process, others learn. And when you handle mistakes with empathy and curiosity, you create a space where learning replaces fear. So none of us is as smart as all of us, especially in healthcare. Medication safety is a team sport, and when everyone shares the same goal, safe, effective, compassionate care, we have good results. And then we stop thinking in terms of departments and in terms of patients, and not who's responsible, but how can we help. So here's my something I wanted to close with. Knowledge is power, and not because it makes us smarter, but because it gives us the ability to act with intention. The more we understand our systems, our processes, and each other, the more empowered we become to protect the patients who trust us. And at the end, I just want to thank everyone for listening to me go on and on. It felt like an eternity for me. Um, but thank you, everyone, for everything you do every single day to make healthcare safer. And it's been my privilege to be with you tonight and share this conversation with you.
Thank you so much, Jill, for this presentation. To everybody listening this evening, our speaker is available to take questions now at this time. And like I said at the beginning of the presentation, you can put those questions either in the general chat box, or you can use the Q&A function at the bottom of your Zoom screen. And Jill, I wanted to let you know that during the part of your presentation, when you were talking about the ways in which environmental design of a facility contributes ultimately to medication safety and error prevention, I know you couldn't see the chat while you were speaking, but there was a comment in the chat. Someone says she totally agrees on the notion of environmental design really contributing to
I
that.
just didn't have a word for it. There's a lot of words
Yeah,
for things now that didn't used to exist.
yes. Um, so while all of you are typing your questions into the chat and or the Q&A function, Jill, I have a question for you to kick us off. So you mentioned during your presentation about the value of human oversight, even when technology is in use and automation is in use in ways that are designed and intended to prevent errors. And you even gave an example of the bubbles in the TPN compounder that you noticed even though the technology didn't. So, and I know I don't mean to put you on the spot here. I'm asking for your perspective on, as somebody who values human oversight of technology, especially in the context of error prevention, where does AI come into that? Or what is your perspective on the use of AI, maybe even in place of human
Mm.
oversight, which we see sometimes or we're starting to see in healthcare?
Yeah, agree. My own company actually is working toward using it for data analytics, things like that, AI. I use it in my day to day, but I interact with it. I don't rely on it. And I think that's the key. I think right now it's not entirely clear how I think everybody's saying yes, AI is going to be used in healthcare in all aspects of healthcare, but I don't think we know the extent of it yet. And I think this would be like a great, like, kind of theoretical conversation to have, because I think it's changing, it's coming on, it's changing and evolving. And people are like going to have to learn to adopt it and interact with it on the fly. Like, it's coming fast. So I think that's a really, I'm sorry, that's probably not an answer, but I think there
No,
could be a
I,
really lively and interesting discussion because it's coming fast, and
yes.
it's everywhere.
Yes. And you did mention that you're not afraid to use technology
Nope.
when it is available to you, which I appreciate. So we do have a question that came in through the Q&A function. So I'm going to read this to you. I've seen administrators and leaders discourage pharmacists from contacting prescribers about their medication errors to let them know what happened. Because of this, I've observed that prescribers make the same prescribing errors, not knowing sometimes that we correct this on the back end. Seems like it would be helpful for prescribers to receive that feedback for patient safety. What are some best practices to encourage that communication back to providers?
Wow, I think that's an excellent point, because as soon as I was really thinking through that, as soon as I heard that, that is true, because pharmacists will do their interventions, but then what? That person doesn't know what, there's no feedback loop for that. And I've noticed that as well. I think that's like a paradigm shift, like a culture change. Something needs to be led from the top down. And, and I'm not sure, as providers, probably, in my experience, sometimes don't like to be questioned, or maybe don't want to take the time out to that for that kind of learning or feedback. And I think it needs to be encouraged and embraced and accepted as a best practice. But I think that's, again, like a top down cultural change to make that happen. But I totally agree with that.
Jill, I would add to that, as somebody who um, is in and out of a lot of different facilities and health systems, is that something that you see with any frequency where there is actually that sort of backwards communication to the original, let's say, error maker
It's
to
not.
let them know what happened? Mm-hmm.
It's not. And I think that I found I find pharmacists to be very open to that. Like I said, if you're like, hey, I saw this has happened. Oh, thank you for letting me know, and they're very open and honest about that. But I have not seen that modeled. And just like you, I travel to hospital pharmacies all over the country. I have not seen that practice in play.
Mm-hmm. All right. I'm scrolling through the chat here. I hope I'm not missing anybody's question. There are a lot of chats coming in thanking you for your informative presentation, Jill. So if
Absolutely
nobody
my
else
pleasure.